Good evening and welcome to the Sadhguru Center Speaker Series. This month, we are excited to have a speaker with us from Canada. And my name is Tulsi Chase, and I'm the Head of Education and Outreach at the Sadhguru Center for a Conscious Planet. And we're really happy to have you all join us today for our monthly event, our online speaker series, where we present virtual lectures and discussions highlighting the research and explorations of our multidisciplinary community of scientists, global experts, and thought leaders. So for those of you who are joining us for the very first time, Sadhguru Center is a multidisciplinary research center based at the Department of Anesthesia, Critical Care, and Pain Medicine at Beth Israel Deaconess Medical Center here in Boston. We aim to bring tools of well-being to both patients and healthcare providers in order to enhance consciousness, cognition, and compassion. And our work really happens at the nexus of research, education, and outreach. We offer wellness programs, conduct scientific studies in various communities, and bring together world leaders from diverse fields to collaborate and innovate health and well-being solutions. So if you want to learn more about our center, there'll be a link in the chat. But I'm very excited today to welcome our speaker, Dr. Maitreyi Raman. She is a gastroenterologist and physician nutrition specialist, also a clinical associate professor in the Department of Medicine and Division of Gastroenterology at the University of Calgary. She completed medical school at the University of Ottawa and then Internal Medicine Residency at Dalhousie University, subsequently followed by a clinical nutrition fellowship at the University of Toronto. Dr. Raman has clinical and research interests in lifestyle as primary therapy for patients with digestive diseases. And she investigates using dietary patterns and components in the management of digestive health disorders, as well as investigating the role of diet to modulate the gut microbiome and chronic inflammation in inflammatory bowel diseases and irritable bowel syndrome. In addition, Dr. Raman explores the role of the brain-gut axis through mind-body interventions and its impact on chronic disease outcomes. So we're so excited to have her with us today to talk about yoga for irritable bowel syndrome. And in today's talk, we'll be describing and looking at the prevalence and the impact of IBS, and also looking at and exploring how yoga could be potentially a treatment strategy for patients with IBS by reviewing some research results and perspectives. So welcome, Dr. Raman. We're so happy to have you, and the floor is yours.
So thanks again for that introduction. And over the next 30 minutes or so, I will describe to you the prevalence, clinical presentation, and pathophysiology of irritable bowel syndrome, which I will refer to as IBS from here on in. Describe an approach to IBS management. Discuss the role of mind-body therapies in IBS management, and finally review the results from a recently completed randomized controlled clinical trial here at the University of Calgary, exploring the role of yoga as a treatment option for IBS. So first, IBS is a very common condition affecting between 12 to 20% of the population. And it typically presents with an individual having or experiencing intermittent abdominal pain occurring on average at least one time per week, associated with change in bowel movement, such as constipation, diarrhea, and or mixed patterns, so both alternating constipation and or diarrhea. Plus, it can be associated with the change in frequency of bowel movements, ranging from very infrequent bowel movements to very frequent bowel movements occurring on a daily basis. And this constellation of pain, bloating, cramping, diarrhea, and constipation cause a lot of discomfort, impacting quality of life, as well as many other relevant healthcare outcomes, seeking patients to look at various therapeutic modalities to help achieve better clinical management. Now, IBS can be subdivided into three categories: IBS-C, or constipation predominant IBS, diarrhea predominant IBS, or mixed pattern IBS. Now, with with that background, the prevalence, as mentioned, ranges between 12 to 20%, leaving about half of patients who have severe enough symptoms to seek medical advice. And this diagnosis is very challenging to make, as it takes an average patient 9 visits to their primary care physician before receiving its diagnosis. And on the specialty side, it accounts for about 50% of consultations to the gastroenterologist. Now, the IBS patient experiences more hospitalizations and more frequent emergency room visits compared to the non-IBS patient. And in fact, the IBS patient may sustain between 2 to 3 times as many hysterectomies and or cholecystectomies or appendectomies than the non-IBS patient. IBS accounts for a significant loss of productivity, ranging between 9 to 22 days off work annually, costing the healthcare system between $600 to $1,600 in Canadian dollars per patient per year, leading to poor quality of life in a significant proportion of patients. In fact, 14% of patients with IBS will accept a 1 in 1,000 chance of death or serious side effects from a medication in an attempt to try and achieve perfect health. Now, IBS, in fact, is a very simple diagnosis to make. But in fact, as I mentioned, it takes an average individual 9 visits to their physician to achieve this diagnosis. And in part, this difficulty in making a diagnosis comes from the fact that symptoms of IBS are non-specific. They can be found in many other digestive conditions, including serious conditions such as colon cancer and or inflammatory bowel disease. So at its core, symptoms of IBS include abdominal pain, change in frequency and or appearance of the stool, so diarrhea or constipation, and other symptoms that accompany these include bloating and abdominal cramping. Now, typically, first-line testing would include blood tests such as a CBC, which would look at blood counts as well as white blood cell counts to assess anemia or possible infection or inflammatory processes. It will also include other blood tests to check for inflammation, such as stool inflammatory markers and or blood systemic markers, such as the C-reactive protein. Celiac disease, a very common prevalent condition, can present in a very similar manner to IBS. So we would always assess for this via serological blood tests. And in individuals that are appropriate for colonoscopy or higher risk for bowel cancers based on personal history or family history or age, colonoscopy would also be indicated. Now, usually IBS symptoms do not or are not accompanied by red flag symptoms. And red flag features that would lead one to sway away from a diagnosis of IBS would include older age, above 50, blood in the stool, unexplained weight loss, presence of fever, or any abnormal physical exam finding. In the presence of these red flags, then typically further investigation is warranted beyond the blood test described, and referral to a gastroenterologist is required and recommended. Now, coming to IBS, this condition truly is multifactorial in its origins. In the last 10 years, we've really come to understand how the brain and the gut and the brain are interconnected, and inextricably so. So there are many factors that affect the brain or the mind function. And these include factors such as stress, the presence of psychological disorders, including severe, even moderate or mild depression and depressive symptoms, anxiety, and then other factors such as fear, anger, catastrophization, all have their own significant impact on the brain function. And in the presence of any of these factors, the brain's signaling mechanisms to the gut can be affected. And this can occur because of alterations in the neuronal signaling pattern and the neuroendocrine and immunological functions that signal from the brain to the gut. Now, as well, the gut talks to the brain in reverse. So when we think about our diet and our dietary patterns, we know the diet is an instrumental modulator of the gut bacteria, collectively known as the gut microbiome. And as these gut microbiome are very sensitive to the diet and the dietary quality, they can be very responsible for producing various metabolites as described on this slide. And these metabolites, such as the short-chain fatty acids and various inflammatory cytokines, can then signal back to the brain and resulting in further gut-brain crosstalk between the neuroendocrine, neuroimmune, and autonomic and enteric nervous systems. So when any of these factors are disrupted, this can result in gut pain, which can arise from increased sensitivity to pain, altered gut motility, as well as alterations in the perception of pain. Now, this slide further highlights specifically from a neurological perspective how the brain and the gut are interconnected. So through the autonomic nervous system, IBS affects the parasympathetic and sympathetic efferent pathways, as well as the production of adrenal steroid hormones. And in turn, the gut bacteria can produce a wide variety of metabolites that can then signal back into the brain, as well as lead towards some of the other findings we discussed earlier. So when we think about how we presently treat IBS, it is not at all optimal. So current therapies for IBS are very focused on the symptom. So when we think about someone experiencing constipation, primary therapies are directed towards laxatives and anti-constipating agents. In an individual who sustains diarrhea, then in that situation, again, we typically treat these in a very symptomatic, targeted way. Now, at a high level, first-line therapies are usually non-pharmacologic or non-medical in origin. And these include items such as fiber supplementation and optimization, dietary modifications, even items such as peppermint oil have been shown to improve gut, abdominal bloating, cramping, and discomfort. Now, other therapies such as cognitive behavioral therapy, and more recently there are data for gut hypnotherapy. These sort of mind-body interventions, if you will, the data for these are growing and accumulating very nicely. However, practically accessing these therapies is challenging for the average patient, as these require expert providers to help with implementation, and frequently they come with cost. Now, after an individual has tried these non-pharmacological therapies, then there are other adjuvant medical therapies that can be tried, again, to try and optimize this gut-brain link, such as antidepressive agents, antispasmodics, laxatives, etc. But even despite these current therapies for IBS, patients are still dissatisfied with the results, leading to 50% of patients who actively seek alternative therapies. Now, here I'd like to describe to you or share with you this slide of yoga and the possible mechanisms through which yoga may have an impact in IBS pathophysiology. Now, most of you are likely very familiar with the various limbs of yoga highlighted on the far left. Now, specifically, when we look at the three boxes in red, so the asanas, pranayamas, and meditation or dhyana, these have formed the focus of our research group's primary interest. But collectively, these various limbs of yoga have been demonstrated to have a significant impact on the hypothalamus and pituitary axis, leading towards decreases in some stress hormones such as cortisol. There are also data for the benefit of yoga on optimizing various neurotransmitters, and these are mentioned here on the slide. Some key examples include modulation of GABA, dopamine, serotonin, as well as others. And very recently, there have been some data to support its impact on neurotrophic growth factors such as BDNF and alterations or modification of the immune system. So collectively, when we look at these scientific components, we see that these can have a role to play in clinical outcomes, such as the improvement of depression, anxiety, negative symptoms, improved cognition, sleep, as well as attention. Now, what about other studies and their impact in IBS? Now, there in fact have been 6 other randomized controlled trials that have been published over the last 7 to 10 years, investigating the effects of yoga in patients who have been diagnosed with IBS. And in these 6 randomized controlled trials, there have been collectively a total of 273 patients who were included in a recent systematic review or meta-analysis. And this meta-analysis of 273 patients found that yoga did improve symptoms of gut pain, so visceral hypersensitivity, as well as improvements were observed in quality of life, stress, and yoga was found to be safe in this meta-analysis. And yoga, in fact, was found to be either more effective than standard of care therapies or equally effective compared to gold standard therapies that have been approved for IBS management. But the authors concluded that although yoga is safe and feasible and perhaps effective, because these 6 randomized controlled trials were very heterogeneous or very different in terms of the duration of the study, the duration of the actual practices, and the components of the practices, the authors could not provide any specific recommendation for yoga as a routine intervention due to a variety of methodological heterogeneity and unclear risk of bias from these studies. So after we reviewed these research studies, we identified several gaps in the field of yoga as relevant to the IBS patient. First of all, we started to think about this right at the onset of COVID, so more than 2.5 years ago. And at that point in time, the role of virtually delivered yoga programming was unknown for the IBS patient. Further, it was unknown what the role and the attitudes of the patient with regards to practicing yoga when diagnosed with IBS was. Further, it was unknown how the gastroenterologist viewed yoga and its possible role to be recommended as a therapeutic solution for the IBS patient. And finally, we wish to understand how patients felt or their experiences after engaging in a yoga-based study. So with these gaps identified, my PhD student, Adriana Da Silva, and I led, first of all, this randomized controlled trial, whereby we wish to assess the effectiveness, feasibility, and safety of a virtually delivered yoga intervention in patients diagnosed with mild to moderate IBS. So we randomized patients to either an 8-week virtual yoga-based intervention or an advice-only control group. And we randomized, and for inclusion, patients were required to have at least mild to moderate IBS as determined by the IBS Symptom Severity Scale. So apart from effectiveness on the primary outcome measure, which was the IBS Symptom Scale, our secondary outcomes included quality of life, depression, anxiety, stress, fatigue, somatic symptoms, COVID-19 stress, as well as self-compassion measures. And we also assessed feasibility outcomes based on attrition from the study, adherence to the study components, as well as the safety. So to be eligible, patients were required to have a diagnosis of IBS as determined by the Rome 4 gold standard criteria, had to be between the ages of 18 and 70, and score at least 75 out of 500 points to meet the diagnosis of mild IBS. And patients required stable medications, stable dietary patterns, and physical activity without any changes at the time of study entry or throughout the study. Patients were excluded if they had any major physical impediment that would limit themselves from participating fully in the yoga program, or if they had any major severe cognitive, psychological, or psychiatric disorder that would limit full compliance and participation in the program. So this was an 8-week program whereby the yoga facilitator conducted a weekly virtual class with the participants. And the participants were also required to engage in daily home practices. In week 1 of the program, so they learned the program components sequentially. And in week 1, they learned the Upa Yoga directional movements as well as Yoga Namaskar. And during this period of time, they required they were encouraged to practice daily. In week 2, they learned alternate nostril breathing, and with similar requirement for weekly or for daily practice in week 2. In week 3, they learned the Om mantra meditation, and week 4, they learned the breath watching practice. Now, from weeks 5 to 8, they combined all of these practices. They still met with the yoga facilitator virtually for practice corrections and enhancements. And there was a requirement for daily practice as well during the remainder of the study period. So I'll walk you through our results. So on the far left, we see the results for the treatment group or the yoga group. And then on the right, we see the results for the control group. So in total, we recruited 79 patients. And we see that compared to baseline at week 8, there were significant improvements observed in overall IBS symptoms, as well as significant improvement in quality of life. We also saw significant improvements for fatigue, as well as COVID-19 stress in the yoga intervention group. Now, to our surprise, we did not find any changes in depression or anxiety measures, although there was a trend towards significance for depression. But having said that, most of our participants only described mild depression symptoms at the time of study entries, possibly suggesting a floor level to observing any significant improvements. Now, on the control side of things, we did not notice any significant improvements within the group for any of the parameters, with the exception of COVID-19 stress. Now, when we compared differences between groups, we saw significant improvements for quality of life, as well as fatigue, as well as overall stress. Now, the average class attendance was 79%. So that meaning that the participant attended 79% of the online virtual classes. And through the 8 weeks, treatment participants or the yoga participants accumulated an average of 1,221 minutes of doing yoga in this period, which translated to 21 minutes per day. Now, coming to our other gaps that we identified outside of the clinical trial, we wish to identify both patients' attitudes as well as gastroenterologists' attitudes towards recommending yoga as a therapy for IBS. So we wish to identify the attitudes of patients, the subjective norms and perceived behavioral control for intention to practice yoga. So basically what this means is we wish to identify to what extent patients find or think that yoga will be beneficial to their health. That's what we mean by attitudes. By subjective norms, what that means is that we wish to identify what other factors might influence a person to practice yoga. And previous literature would suggest that important influencers in that patient's life, so whether it be a spouse or a parent or a child or a physician or some member, what would they think about the patient practicing yoga? So that's what is meant by subjective norms. And then behavioral control means to what extent will the practice of yoga be easy or difficult? And historically, these types of factors have recommended or suggested that intention to engage in or have predicted intention to practice any kind of physical activity or behavior. Now, similarly, we wish to identify the gastroenterologist's attitudes, their perceived supports, any barriers or facilitators to recommend yoga as a therapy for IBS. So to do this, both patients and gastroenterologists completed validated online surveys that were developed using gold standard techniques. So for the patients, we enrolled 109 patients, and we identified these three important factors: controllability, to what extent is yoga easy or difficult, self-efficacy, how would they feel after they did this, and to what extent do they feel that participating in yoga will have a benefit on their overall symptoms. So we found that controllability and feeling that it would have a benefit on their symptoms were significantly associated with the patient's intention to do yoga. So if they felt they could control it and they felt it would have a benefit, then they're more likely to want to engage in the practice. But interestingly, in our study, over the 8-week period, the intention to do yoga decreased over time. So meaning when you surveyed the patient, did they wish or will they continue doing yoga? They answered no. So although I showed you all of those improvements on various outcomes, they stated as the study went on that their intention to continue yoga decreased over the 8 weeks. But what was even more interesting than that was that, interestingly, although they said they would not practice yoga or that they were less likely to practice yoga, it did not correlate with their weekly practice minutes, meaning that they did yoga anyway. So their intention decreased, but their practice did not. And so we concluded that intention perhaps was not the only predictive factor of engaging in yoga, and perhaps there are other variables that need to be considered in future studies that may predict practice minutes. Now, coming to the gastroenterologist, we surveyed 79 gastroenterologists across the country, and we identified that GIs who have confidence in recommending yoga, of which there were 39%, were 7 times more likely to recommend it. And those gastroenterologists who agreed that yoga improves IBS symptoms, either based on experience or based on the literature, were 10 times more likely to recommend yoga. But we concluded that although gastroenterologists believed yoga is safe and beneficial for IBS, most do not recommend yoga, mainly due to a lack of confidence in doing so. They wouldn't know where to recommend, what kind of program, what kind of duration, what kind of monitoring, and also they felt the scientific evidence was still not robust enough to support a role, despite the 6 prior randomized controlled trials I discussed earlier. So now when we talk to patients, 41% of participants rated the program as excellent, with 30% as great and 29% as good. And all participants strongly agreed the practice videos and feedback on their practices were helpful. And they agreed that the yoga facilitator was knowledgeable and approachable. And 52% of patients strongly agreed they would recommend the program to other IBS patients, so strongly agreed. And although not presented on this slide, 40% of patients agreed they would recommend the program to other IBS patients. So in terms of future directions, we clearly identified a need for the gastroenterologist around education as well as resources so that the physician can confidently recommend yoga and recommend resources to patients who are interested in pursuing this as a therapy. We also identified the need to understand predictors of yoga practice, because in our study, intention did not predict practice. So what other variables could potentially practice or could influence the patient's behavior to continue practicing yoga? Patients told us they would like to see both virtual as well as hybrid interventions. And finally, we feel it's important to engage stakeholders such as payers and funders to facilitate yoga-based therapies at lower or no cost. So we would recommend future studies be multi-centered randomized controlled trials with an active control group, ideally gold standard control groups such as dietary interventions or pharmacological therapies. I mentioned earlier there are 3 subgroups of IBS: diarrhea predominant, constipation predominant, and mixed pattern. Does yoga preferentially affect any of these subgroups? What is the optimal dosing of yoga? In our study, it would appear that 21 minutes of practice per day would achieve significant improvement on the various outcome measures. And what are the mechanisms of action? I discussed earlier some work that other groups have done. We're in the midst of trying to understand the effectiveness or the effects of the gut microbiome in patients who are yoga responders versus non-responders, and how does the autonomic nervous system factor into the benefits observed with yoga for the IBS patient, where clearly the nervous system, the autonomic nervous system in particular, is a clear mediator of results. In the last few minutes, I'd just like to highlight a few perspectives. So for patients with digestive health conditions, diet and lifestyle therapies are undoubtedly first line for many digestive diagnoses. And these include items such as diet, weight management, mental health improvement, fatigue, and sleep and stress management. But in the 30-minute consult time that a patient has with their gastroenterologist, between 10 to 15 minutes are usually dedicated towards symptomatic discussion. So discussing the course of symptoms, discussing medications or strategies that patients have tried or had previous experience with. Then the next 5 to 10 minutes in the clinical environment are usually dedicated towards investigations, colonoscopy, ultrasound, etc. And the last 5 minutes or so, or 5 to 10 minutes, are spent discussing various medical treatment options. But this leaves no time in the clinic environment to talk about diet and mental health and weight management and all of these other important things, especially now that the evidence for mind-body interventions is growing. So we saw this gap, and we've heard from patients about this gap, and that has led our group to develop a virtual solution called LifeMD, which is a mobile application solution to help optimize diet, mental health, and wellness strategies for the patient with a gastroenterological condition. So the LifeMD approach includes optimized diet plans based on personalized needs. It includes yoga, breathing, and mindfulness programs to improve sleep, stress, as well as overall well-being, in addition to cognitive behavioral therapy, self-help programs to improve mental health as well as behavior change, and physical activity programs to improve strength, heart health, as well as activities of daily living. These are just a few examples of the application slides. For now, we have programs for patients with Crohn's disease, ulcerative colitis, non-alcoholic fatty liver disease, IBS, which is our healthy gut microbiome program, as well as inflammatory arthritis. Based on the condition, the diagnosis, as well as validated surveys, personalized recommendations for diet, as well as mind-body management are employed and recommended in the program. And a health coach who is attached to the LifeMD program will help the patient walk through the program that is best for them. Hearing the feedback from our patients about the experience in our studies has led us to make some refinements to the program. Continually, the LifeMD program is undergoing revisions in response to patient feedback as well as patient needs. So the yoga, breathing, mindfulness program includes a combination of videos as well as audios and still shots, and has programs to meet the patient where they're at in their journey. So if they only have 5 minutes before they're driving their children to school in the morning and they wish to do a breathing program, they can do that. But if they have an hour before bed and they wish to engage in a yoga nidra program or a nighttime meditation program, then that's an option too. So this application is available free of cost to anyone living in Canada. So in conclusion, IBS is a prevalent disorder that impairs quality of life. It results in increased healthcare utilization and is associated with substantial direct and indirect costs. Lifestyle solutions are effective to manage IBS as first-line solutions. Virtual yoga is effective and safe to treat IBS and is feasible. And digital strategies for lifestyle management for digestive diseases are available. And our goal is to try and have the LifeMD application available in the United States in early 2023. So with that, I'd really like to thank you very much for the opportunity to present today, and I'm very happy to take questions.
Maitreyi, thank you so much. That was really wonderful, and this is what you do, right? So it's great to hear from the doctor who's taking care of his patients. The question to you is, you mentioned about the yoga study that you and your postdoc did, and the challenge has been the fall, even though they have the intention to do it, they will not do it as time goes on, right? Did you find that having this app is actually improving that adherence, and because it's like a multi-component bundle, is that making things better for them to stick to the intervention?
Yeah, so that's a great question. So this application was not used in our randomized controlled trial. So I can't answer that question with robust data. Having said that, we are using the LifeMD application in another randomized controlled trial that is underway. And we're finding that, so the patients have the option for either using the app on its own or employed with a health coach, and the coach is familiar with all of the programs. And very clearly, it's demonstrating that having a health coach assist the patient with all components of the application has been really important to maintaining adherence with the program and enhancing the outcomes. So for example, before we had the health coach available, patients were interacting with the application about 20% or maybe 2 times per week on average for maybe 5 minutes. But since we've had the coach come on board, patients are interacting with the application 6 out of the 7 days per week, and their clinical symptoms have improved significantly so. So we think having a tool, a virtual application is important, but having a coach or a live individual to guide the patient is perhaps even more important.
That's great. Do you think is it because of having these multi-components that's making the difference, or is it even if a health coach with one component would make a difference?
Yeah, that's great. I think the multi-component option is important because some people have, depending on where they are, especially an IBS patient, where they are in their journey, they may have more of a need for a mind-body intervention. Others may have more of a need for a diet intervention. Others may need, a physical activity intervention. So understanding where the patient is on that journey will help us understand where we should start with the patient, because we don't want to overload them too much cognitively, because I think that creates some confusion and it can lead towards attrition as well, because people feel very overwhelmed. So knowing what the priority is for that patient can help us start with that program, and then we can move into the other domains as the need and as they become more comfortable with that first component.
Great. Thank you. I see that there is Tony Lembo, who's a gastroenterologist at our hospital, and he has been interviewing some of his patients. Tony, do you have any comments or any questions?
Thank you. And Dr. Raman, thank you so much for that wonderful presentation. And I had a few questions, but I agree completely, and I'm really interested in the app that you have, because it clearly is the way we want to be treating patients in the future. But in your trial, the control group, I know it was a tension control, but did they spend the same amount of time as the people doing, a lot of minutes that people spend in yoga? Was it similar amount of time?
You know what? So we just submitted our paper to American Journal of Gastro, and they've reviewed it, and we're waiting a decision from them. And that was one of the questions they had for us as well. So what did the control group do, and did we capture any data around that? Unfortunately, that was a limitation of our study. So we recommended the control group were provided resources from the Canadian Digestive Health Foundation about the role for the mind-gut axis or gut-brain axis in mind-body interventions. And they were also provided a video that I did for them, basically describing the science or the physiology, pathophysiology of IBS. But we did not capture any data around the time, like whether they even interacted with those resources, and if so, what kind of practice did they engage in. So unfortunately, I'm not able to provide those results.
That's great. And the study that you're doing now with your app, do you have a control group, or is it just a longitudinal type study that you're going to be doing?
We have a control group. So right now we, our first study, which is nearing completion, is for patients with IBD. So we have enrolled 40 patients with either Crohn's disease in remission or ulcerative colitis in remission, and we have 40 control group patients as well. And they have been provided the application for 8 weeks, and our primary outcomes are quality of life, symptoms, so Harvey-Bradshaw index, as well as we're looking at stress, depression, as well as anxiety. And we are collecting stool samples on all individuals as well to see if there are any changes in calprotectin or microbiome factors. Now, learning from that study, we have now, or actually we've just got ethics approval. We're about to embark on something very similar for IBS. The IBS program is very different, though. It'll be multi-component. So there is a low FODMAPs diet component, as well as or a Mediterranean diet component, depending on what's right for the patient. And then we have this yoga intervention, which has been refined based on patient feedback. And we also have a physical activity program and a control group that will continue on their usual therapies without any changes in any of their therapies.
That's great. Look forward to seeing that. Thank you.
Thanks.
Tony, thank you so much for your comments. And Sadhguru, I think, is also on the Zoom call. Sadhguru, do you have any comments? Maitreyi, I don't know where you know Sadhguru. He's a long-term yoga researcher, established yoga at the Harvard circles, and he's also editor-in-chief of one of the major international yoga research journals. If it's getting online, Maria, I think you had a question you want to ask. Maria Goncalves is a postdoctoral research fellow with us.
Yes, sure. Hi, Maitreyi, thank you so much. It was a very nice presentation. I have a couple of questions more regarding the design of the study. Did you follow up those patients in the long term to see if the improvement of those symptoms were lasting longer? Or?
Yeah, so we haven't done any long-term follow-up with these patients. So that's a really good point. What we have done, we did collect stool samples from a subset of all of these patients, and we are planning a fecal microbial transplant study as our next step, whereby we will take stool samples from yoga responders based on IBS symptom severity score, and basically transplant them into an animal model of IBS, basically to try and understand mechanisms that may, through which IBS may in part arise from. So our next more immediate steps are translational, translational in terms of trying to understand the mechanisms.
Yeah, the reason why I'm asking, because the patients you mentioned, they didn't intend to continue doing yoga, right? And this could be that probably once they feel that their symptoms are getting better, they kind of don't want to keep doing it because it is already feeling better. But if in a long term they feel like it's not sustained, maybe they would keep doing the practice for a longer period.
Yeah, that's a great point.
And the other question was also regarding the daily practice. So how was you recording this daily practice, like the minutes of practice? Was it self-report?
It was self-report. Patients kept a log. Our research coordinator checked in with the patient on a weekly basis. So it was self-report facilitated by the coordinator.
Okay. Do you think that this could be somehow associated with this non-correlation with the intention of keeping doing the practice? Because they were self-report, sometimes they inflate their answers.
It's possible. We, as part of our future directions, we would like to do some measures of autonomic function. Whether or not that's necessarily a measure, whether or not that's mechanistic versus helping us capture yoga practice, perhaps they're interrelated. I think that absolutely is a future direction. That's possible.
Okay, thank you.
For any chat questions, seems like you already answered that. Is research still ongoing with the effects of the illness and the app usage? So that's great. Are there any, you said this app is completely free for Canadian people. So how is this funded?
Yeah, so you know what, I should say that it is completely free for patients living in Alberta. So Alberta is the province in which I live in. So for Canadians, it is free of cost for patients with inflammatory bowel disease. Largely, this has been supported very heavily by our industry partners. But for IBS and the other conditions, there is a cost for accessing the application outside of Alberta. Within Alberta, we've been very fortunate to work with our frontline pharmacies, and the pharmacies are also very committed to inspiring wellness in patients. So at least for the foreseeable future, we have funding from the frontline pharmacies to help patients who are interested in accessing the application at no cost.
Oh, that's fantastic. That's really helpful. One other thing is, since younger people are more affected with this disease, how are you disseminating your findings to them, and also the availability of your app, because they're probably more app friendly?
Yes, exactly. So so Adriana, my PhD student, has done a tremendous job in trying to raise awareness through social media. So she has or either will be, I think this might be her priority moving forward, to disseminate these results on social media, as well as disseminate our findings through patient organizations like the Canadian Digestive Health Foundation, as well as present at various scientific conferences. But and also locally, we've been very fortunate to have all of this work supported by the Imagine Group. And the Imagine Group is a scientific community that engages several hundred digestive health researchers that are interested in lifestyle determinants of GI conditions. So particularly IBD and IBS are the focus. And Imagine is very well connected with government stakeholders. So as part, now that the science is there, the next steps are to engage our government colleagues and try and raise awareness about the role for lifestyle and try and increase awareness and education about the resources that exist.
Thank you, Maitreyi. Last Tulsi, if you want to take over.
Thank you so much, Dr. Raman. I actually have another question. So the practices, the yoga practices that you shared in the study that you did, the initial study that you sort of looked at in a little bit more depth, are they the same or similar yoga practices to what is available in the app?
No. So the initial study where the components that I described were all components from the Isha Foundation. And then based on the feedback that we have received, we revised the program fairly significantly, I would say. And those revisions are what is in the app.
So what kind of feedback did you receive from patients that made you sort of make those changes? I'm just curious.
Yeah, we haven't published that paper yet, but that paper is coming. And so we did a qualitative study in a subgroup of these patients that went through the program. And some feedback included, they felt that some components of the program were more relevant to IBS, and those are the types of features we kept versus the things they perceived to be less relevant. So the less relevant features were the items such as the directional movements and yoga namaskar. They felt that this was less important for them. They felt they derived the greatest benefit from alternate nostril breathing, as well as from the breath watching. And surprisingly, because this was largely, largely a Western audience, they did really enjoy the Om chanting. So in the past, we've had mixed opinion and feedback on the Om chanting, but in this case, it was felt to be a highlight. So so there were some components about how it was delivered and how and sort of the time duration that was attached to that. So the modifications, so we retained a lot of the essence, but we modified it in a way that they told us seemed to work for them.
Thank you. That's super helpful because I'm also working to design some yoga programs for our different patients at our hospitals. So I'm really happy to hear feedback like this that's qualitatively gathered. I'm curious if you also did some qualitative assessments to understand more deeply why patients didn't feel like they intended to continue to do the practices. That was something that I was curious about.
That's an interesting question. No, we did not do that. Having said that, the people that we interviewed qualitatively likely were the people that really enjoyed the program. And so I suspect these may not be the people that would say that their intention to practice decreased. So we offered the opportunity to everyone to participate in our qualitative, but we reached sort of data saturation after we interviewed, I believe, 16 patients, 16 of the 79. So those 16 patients probably were the most motivated. So I don't know if I think what I'm trying to say is we probably would have had to interview many more patients in order to find those patients in whom who declared that their intention to practice decreased.
Thank you. It's really interesting to learn some of the details behind and how the study was conducted and patient experiences. And I hope that we can continue to learn from this incredible wealth of work that you're adding to as we speak. And thank you again, Dr. Raman, for sharing your work with us today and sort of opening up this world of IBS and yoga and how they can collaborate and the possibilities that exist here. We're really, really happy to have had this chance to hear from you today.
Thanks very much for inviting me, and it was a pleasure to speak with all of you today.
Thank you so much, Maitreyi. Have a good evening. Thanks, everyone.
So before we close, I just want to quickly share my screen and just let you all know about the ways that you can continue to stay in touch. So if you enjoyed today's conversation and learn something new, please make sure to join us for future speaker series events. The best and easiest way to find out about our future events, not just our speaker series, but all types of programs and ongoing events and opportunities, is to connect with us on social media. These are our handles. They're Dr. Bala's handles. And it'll also be shared in the chat. So you can just click on those links and connect with us directly. And upcoming next month, we have a really interesting talk with Dr. Elissa Appel, who will be sharing about stress and aging and looking at how psychological stress impacts cellular aging. And Dr. Elissa Appel is a professor and vice chair at the University of California, San Francisco, and she studies contemplative health psychology, specifically looking at how chronic stress can impact mental health and biological aging throughout the lifespan. including intergenerational transmission of health, and how contemplative interventions like yoga, meditation, etc., and some of the things that we talked about today may promote emotional well-being, resilience, and physiological thriving, especially in the face of existential stress. So it'll be really wonderful to have you all join us next month for this talk. The link to sign up and register for this talk, which is free, is also going to be shared in the chat. And finally, if you have any further questions about the work that we're doing, if you want to connect with our speakers or sign up for our mailing list to know about our upcoming events, the information is on this slide. You can email us at any time, connect with us on social media, and you can use the QR code on the bottom left corner to get updates on any future events and programs with our center by filling out the interest form linked to that QR code. So thank you once again, everyone, for joining us today, and you can feel free to reach out to us anytime with questions or ideas. We look forward to hearing from you, and I hope you all have a wonderful day ahead.